Good morning, guys. This presentation is about the Safewards method of dealing with psychiatric patients in an inpatient setting. It was developed by some researchers at King's College in London, and in clinical trials, it's had excellent results. So let's move on to the method. So first, a quick review of the evidence. Bowers and some colleagues used a randomized trial involving several inpatient psychiatric wards. They developed 10 different interventions, and they also had a control that included some things like self-help magazines and outings and things like that. So it is randomized and controlled, and they were able to determine that when these units were faithful to the Safewards method, there was a decrease of about 23.6% in the need for containment, which includes, medications like Haldol, Ativan to restrain patients, and then physical restraints. There was also a decrease in conflict by 14.6%. Those are significant results. So we can conclude that the Safewards method as a whole does work. I am only going to talk about 2 of the interventions today because on our unit in the ER, we don't have control over some things like, we don't have control over how nice the furniture is or whether the doors are locked or where the patients are placed as much. So we can only change what we can change. So I'm going to talk about the use of soft words, which are not just words, but some of them are attitudes and approaches to dealing with different situations. And then I'm going to also talk about the 3-step talk-down method for dealing with when the patient does become upset and there is a flashpoint. So real quickly, this is the Safewards model. This is where they kind of got their idea for the interventions from. They postulated that there were 6 basic originating domains that influenced how flashpoints and conflict originated. So you can see there's outside of the hospital on the left there, physical environment on the left bottom, staff team, regulatory framework, patient characteristics, and patient community. And in each section, I don't know if you can see very well, in each section there are staff modifiers in between the originating domains and the conflict and containment section. So that just kind of gives you the idea that there are things we can do to moderate all of these influences. So let's talk about originating domains. The ones we can't change are these 5 on the right over here. We can't necessarily change any of them. So patient community, that includes their family conflict, their friends, their little world. Their characteristics, they may be paranoid, hallucinating, they may be influenced by their mood disorders, euphoric or depressed. Then the regulatory framework that influences us as the staff. We have legal constraints like emergency detention orders from the police and our hospital's policies. The physical environment is another thing we can't change necessarily. We are working in the ER and we have the furniture we have. We can't change that. Outside of the hospital, the larger picture of our environment, our city, our culture, world events also influences us. So these are things that the nurse can't necessarily influence. However, the staff team, our attitudes toward the patients, these are modifiable. So that's what we're going to focus on. This has a really strong influence on whether the patient needs containment and whether conflict arises. It involves our internal attitudes, the speech that we use and the way that our body language is, and then our actions toward the patient and our character, our consistency with what we say and what we do. In a 1995 study, Lancey, McKay, Gallup, and Toner actually showed, it's an older study, but it's still important, they showed that nurses' limit-setting styles predicted conflict. So for people that were not impulsive, when the nurse used an empathetic style of limit setting, like if she had to say no, she let the patient know that she sympathized with them. She didn't use judgmental language. Her tone of voice was kind. In those situations, there was less conflict. It did not work as well with impulsive individuals, and a lot of our patients are going to be those types of individuals. So, but it's good to keep in mind that for the patients that we can modify our approach and get a good result, we can use this approach. So when I was looking at the interventions that Bowers used, I chose soft words because I really like how it's kind of a comprehensive approach. The aim of soft words is, quote, to improve the language used by staff and therefore assist them in working collaboratively with patients. Sometimes we're not aware how we come across to other people. Sometimes we are aware and we're just not being careful with our language and our actions. But being reminded of this stuff, what they did, they posted these soft words, I think one a day, in the staff room for people to read, which would be a really great thing. I have several of them posted in the hallway of the ER on the safety board right now. But just as a reminder, every morning when you come into work, how to approach the people that you're dealing with. And this really works for everybody, not just psych patients. A lot of people that come into the ER are upset and frustrated. And when you approach them in this way, if they're reasonable, this will help. There are 4 basic themes. So one being respectful and polite, using both verbal and nonverbal methods. It's really kind of just the golden rule, which is to do to other people like you would want them to do to you. Then number 2, turning down a request. So sometimes you're going to have to say no to psych patients. As with anybody, justify your answer. Explain to them, because they're an adult, or I mean, they may be a kid, but they're probably an adolescent. You can explain to them on their level why you have to say no. And then number 3, sometimes you'll have to ask a patient to do something. So be flexible, compromise, listen to their feelings, and let them have the last word. If they want to say something ugly to you, as long as they're doing what you ask them to do, like, hey, you need to go back in your room and lay down in your bed. If they say something rude to you, let them walk away. Don't say anything back. And then 4, if you have to ask a patient to stop doing something, also, they need an explanation. And if you can choose to ignore a minor thing, kind of like the last word idea, if you can choose to let it go and it's not something that's going to cause a huge problem, just let it go. So these are just some examples of soft words. I chose some of the ones that I thought summed up what some of the other ones just suggest. And you can kind of read over these. But basically, they involve giving attention to the patient, using formality in your approach, so addressing them as Mr. Smith, Mr. De La Rosa, whatever their name is, making sure that you're paying attention to your body language, so you're not frowning, you're not crossing your arms or wagging your finger at them, squinting your eyes, that you are facing them when you're speaking to them, and that your tone of voice is warm and compassionate. Here's some more soft words. I think an important one is this one up in the right upper corner here. A lot of the time we can get a little bit lazy, and so when somebody asks us for something, our first reflex is, no, I can't do that right now, I'm busy. And that isn't a good impulse. So if there's a way for you to help the patient out or to compromise, you should seek that out. Like, a lot of the time these people are smokers. So if they ask you, can I go outside and smoke? No, you cannot go outside and smoke, but don't say it like that. You have to put their safety first. They cannot go outside and smoke if they're in an emergency detention order. But I can get you a nicotine patch. Let me ask the ER doc for an order for a nicotine patch. Okay, it's going to be a few minutes. It might be an hour before pharmacy gets that to me, but I'm going to go ahead and ask him, and I'm going to put that order in now, okay? That's all you have to do. Go ahead and manage their expectations so that they don't think they're going to get it immediately. They know it's going to take a little while, that you have to find the ER physician in order to get the order. Explain what you're doing, just like you would want someone to do for you, so that you won't be wondering what's happening. This one in the middle kind of talks about the strategic blindness, which I think is a really good idea. It's hard to do, and in some cases we'll have psych patients all kind of in one area, and so if one patient starts to act up, it stirs the other patients up. So you're going to have to kind of use judgment. If it's something little, you might be able to ignore it and it might leave the area in peace. If it's something that's going to cause problems, you're going to have to delimit that. You're going to have to either call for backup, go in and talk to the patient, kind of reason with them, get them to stop doing whatever it is. You need to always make sure that you're polite and respectful. And I think that most people kind of understand how to be polite and respectful, but don't necessarily notice when they're not being polite or respectful. So you're going to have to think about how you might look to the patient. And then finally, admitting fallibility. You might be wrong. It's hard for medical professionals to do this because decisiveness is valued in medicine, and for a good reason. Confidence is valued in medicine, but we can be wrong, and it's not wrong or weak to admit that we may be wrong because we're human beings. So it is okay, and it's actually desirable that you admit that the rules might not be the best. This might not be the best situation or response, but we're just doing the best we can, and just emphasize that you want the patient's safety to be safeguarded. So this poster is the 3-step talk-down poster for when a flashpoint or conflict occurs. I had an example of this from my own experience. I had a 17-year-old in the ER. His mom was not with him. She needed to be with him. He did not know he was going to be transferred to a psych facility. The ER doctor had told him he might go home. I called his mom to tell him she needed to come and sit with him, and I was in the area where he could hear me. He heard me on the phone mention that he was going to be transferred, and he got very, very upset. So if I had this plan, I'd kind of maybe have reacted a little bit differently. The first paragraph up here at the top talks about controlling yourself. So when the patients get upset, being aware of your own stress response, like your heart rate's going to go up, you're going to get tense. You need to be prepared for that and be able to kind of slow your movements, make sure that your body looks relaxed even though you don't feel relaxed. Breathe deeply and focus on what you're doing. Try to watch your facial expression. Don't argue or defend yourself. And then also preparing a little in advance, just be ready to respond to insults with something that's not inflammatory. Treat them with respect. Don't mock them. Don't give them advice. Don't act like you know better than them, basically, and listen to them. And then you're going to, number one, delimit. So there's no way to separate our patients in the ER from each other except to go into the room. Don't go in the room with them. You can sit in the doorway and talk to them. If you need security, call them before you start talking to them. Do not go in the room. Do not close the door. Try to make it a little quieter for them, but do not compromise your own safety. You're going to clarify with them what's going on. So for this kid, he was very upset that he was being transferred to a psych facility. I might say, Mr. Smith or Jonah or whatever his name is, tell me what's going on. Explain to me why you're feeling so upset. I don't know, maybe not use why, but to explain to me what is making you feel so upset or what's going through your mind right now. And then listen. Speak clearly to them. You can, you just remind them, like, I'm your nurse. I'm here to help you. I would like to understand what's making you upset and see if I can get you some help. And then when they tell you, repeat it back to them. Say like, okay, I think that I understand that you're really, really upset because you are supposed to go to a psychiatric facility. Is that what you're feeling? So that there's a good understanding between you. And then finally, try to resolve it. It may or may not be resolvable. Give them options. Give them reasons for what's going on. Give them a minute to try to get in control of them. You can make a personal appeal, like you can say, Mr. Smith, remember that I told you if you can be compliant and calm, you are going to further your own discharge. You're going to be closer to showing psych response that you will not be a danger to yourself if they discharge you. And then, apologize, like, I'm sorry that you're stuck here. For your own safety, I cannot let you go right now. Is there anything that I can do to gain your cooperation? Try to end on a positive note. Here's a link, just a quick link. You can watch this, like a 3-minute video on YouTube where one of the Safewards staff members talks about how to use the poster as well. Thanks for listening, guys. I hope you enjoyed this presentation. I hope it's going to help you deal with your psych patients and have a more positive experience every day in the ER.